In the past, we've applied what we call a rule of threes to selection of people who might deserve genetic testing because they might have a gene that's really contributing to the development of their melanoma. And that involved a rule of threes, which was either three invasive melanomas in them, or a total of 3 melanomas in them plus their first and second degree relatives, or melanoma, a total of 3, either melanoma plus pancreatic or astrocytoma cases, because those are also associated with a known susceptibility gene called P16. And that was sort of the rule that we went by to decide who got sent for genetic testing. But the problem is that now, as we've started to do more genetic testing, we're finding that it's not just pancreatic cancer and astrocytoma that's associated with melanoma, hereditary melanoma. There are other cancer cases, breast cancer and colon cancer and things like that, where the genes are a little bit different, but if you could identify those patients, you could potentially then screen them for those other cancers that it might be very important to screen for to save their life, which is what genetic testing is really all about, is to really identify the people before they get the cancer or at the earliest stages so that it can be treated. So now what we've done is we've provided a rationale in a paper that's getting ready to be published that shows which patients, it suggests a strategy for which patients deserve to be considered for testing that includes these other cancers. And it also includes a suggested list of genes that should be used, that should be tested for in those different subsets of patients. And it also, so it builds on the rule of threes that you still get counted up a certain number of points based on sort of how many other cancers you have and what type of cancers you have and what genes are known to be associated with those cancers. So it's a pretty exciting step forward. It's not by any stretch the end game. There's going to be a lot of discussion ongoing in the scientific community about when a gene changes from being something that you report to a patient to something that doesn't get reported to a patient. But by engaging the genetic counseling community, I think that dermatologists can really, really benefit their patients by identifying those that are at risk for a variety of other cancers, not just melanoma. So for example, let's say you have a patient that comes in and they've had one invasive melanoma, and you ask the family history. You say, is there anybody else in your family that had melanoma? And they say, well, yeah, I had an uncle who had invasive melanoma. Well, what about other cancers? Are there any other cancers in your family? And they say, oh yeah, we have a strong family history of breast cancer and prostate cancer on that same side of the family. And but we don't really understand why. And you start to articulate it, and it turns out that they've got 3 prostate cancers and 3 breast cancers on that side of the family. Well, that's really unusual to have 2 melanomas, 3 prostate and 3 breast. So how do you decide what they get? You know, what kind of a test is appropriate for that sort of situation? Because maybe it's a breast cancer gene that is happening to also, like BRCA2, that might happen to have a high risk for melanoma as well, right? Or maybe it's a colon cancer gene, like a mismatch repair gene that's causing, you know, some sort of colon cancer. I said prostate, I think, so I kind of messed that up. But let's say it was colon cancer. Let's say it's a mismatch repair gene that also happens to be causing breast and melanoma. Then what you would want to do is you'd want to make sure that you do a panel test rather than just a test that's directed to a melanoma-specific gene. And so what we've been able to try to put together is a rationale for when do you bring in another panel of genes to add to the melanoma genes based on the other family history, right? So you having one breast cancer in the family is probably not enough to go that far, because one breast cancer doesn't mean that you've got a really strong breast cancer history because it's so common. Having one prostate cancer in the family with melanoma isn't good enough because it's so common. It's just by chance that it might be together, right? But if you exceed that value of having 2 other cancers plus 2 melanomas, that then meets the rule of 3, because 2 of those high incidence cancers would count as 1. The rule of 3 used to be that you have 3 melanomas either in an individual or in a first or second degree relationship of a family, or a total of 3 that counted only melanoma plus either pancreatic cancer or astrocytoma. No, I think what's really important is for the dermatologist. Most dermatologists do not have time to order a genetic test, to give the genetic counseling, to go through the risks and benefits and consent a patient for genetic testing. That's just not practical in most dermatologic settings, right? But what is practical is for them to ask a personal and a family history of melanoma and other cancers. And if it turns out that they've got a patient that fits this rule of 3s, to refer them to a genetic counselor who can then use these guidelines as a way of testing the patient for all the genes that might ultimately benefit them. So the idea is, if you do identify, let's say that you have a family that has a melanoma, 2 breast cancers, and a ovarian cancer, and nobody has ever put together that they had a BRCA2 mutation, but you test it when you're testing them because you picked it up with melanoma, then you've now allowed that melanoma patient to be screened for all of the breast and ovarian cancer that they might get, right? And they might not have put that together with without the dermatologist's help.